Yes, I will discuss some particular issues related to the use of hematopoietic stem cell transplantation in adults with acute lymphoblastic leukemia. This will cover the choice of donor, the choice of conditioning, the use of antithymocyte globulin as a part of immunosuppression protocol, and finally the role of post-transplant maintenance. ALL is the second most frequent indication for allogenic transplant, accounting for 16% of all allotransplants performed in Europe. And despite increasing availability of new treatment modalities, new treatment options, the number of allotransplants for ALL is continuously increasing. So this is still a popular, a valid treatment option for patients with acute lymphoblastic leukemia. Now the issue is how to select a proper population who should be transplanted or who should not. And the criteria for this selection vary among countries. We have performed a pan-European survey to identify risk factors that are taken into account for referring patients for transplantation, in particular national study groups. And it appears that all study groups accept the level of minimal residual disease, the status of minimal residual disease, as the most important prognostic factor. And there is a consensus that MRD positive patients should be referred for transplantation, no doubt about it. With the new drugs, including blinatumomab, maybe we would be able to eradicate or to diminish the level of MRD before transplant, thus increasing the efficacy of the transplantation procedure. There are still many countries where also conventional risk factors are taken into account, including high initial leukocyte counts, adverse cytogenetics, adverse immunophenotype, initial CNS involvements, and some particular molecular subtypes that are considered high-risk features. We are living in happy times when all patients who are in need of allotransplant, in fact, can find their donor. Until recently, only matched sibling donors or matched unrelated donors were considered for transplantation in ALL. In recent years, the number of haploidentical transplants increased markedly, and as mentioned, if we need to do transplant, we can do it for everyone. Obviously, these new modalities like haploidentical transplants do still require some optimization. We don't know long-term follow-up. It's not absolutely clear if the outcome is really comparable to matched sibling or matched unrelated donor transplants, but the numbers are growing in our experience as well. So first, we should not forget about allotransplant. We are excited about new drugs, but still allotransplant is the backbone for the majority of protocols and should be applied to the majority of our patients. But we should do this keeping in mind that the conditioning regimen plays a role. Still, total body irradiation is the preferred option as conditioning for patients with ALL. We should not forget about antithymocyte globulin that reduces the risk of chronic graft-versus-host disease. And especially in pH-positive ALL patients, we should not consider allotransplant as the final event, as these patients do really require either prophylactic or MRD-driven preemptive treatment with tyrosine kinase inhibitors after transplant.